There's more changes in hepatitis, in both acute hepatitis and chronic hepatitis, than you might think. So pay attention. We got new stuff here for you. Hepatitis is an infection or inflammation of the liver. The majority of cases were caused and still are caused in acute cases of hepatitis A and B. Hepatitis C, although it's the most common reason to need a liver transplantation in the United States, rarely presents with acute infection. It bypasses the acute infection and people don't feel it. They just show up 20 years later with cirrhosis or needing a liver transplant. It can be found on blood tests for abnormal liver function, and basically you have high transaminases, and hepatitis B and C serology is done. You find it that way. Or in people who are being evaluated for cirrhosis. Hepatitis D is rarely found anymore because rates of injection drug use are much lower than they used to be. Hepatitis D is exclusively a co-infection with hepatitis B and seen in injection drug users. Hepatitis E is described after D, so A, B, C, D, E. It's the worst in pregnancy E, and you eat it, it's enteric, and it's in East Asia, like Thailand, Cambodia, Laos, Vietnam. Hepatitis B, C, and D are transmitted sexually, blood, perinatal. Get it from mom for free, The food and water, the enteric ones, hepatitis A and hepatitis E, or fecal, oral fecal. You ate hepatitis A, you eat hepatitis E. But when they present you a patient who's got yellow skin, yellow eyes, you can't tell which type you have. There's no way to detect the specific type from the symptoms. All forms present with jaundice, fever, weight loss, fatigue, with dark urine. All forms present with jaundice, fever, weight loss, fatigue, dark urine. You tried to lose weight, you tried Jenny Craig, you tried Slim Fast, you tried Weight Watchers, try hepatitis. 20 pounds of weight loss, you don't have to count calories. They all could have a big spleen, hepatosplenomegaly, and they all can cause nausea, vomiting, and abdominal pain. If they present you this, you cannot answer the question, what's the most likely diagnosis in terms of, is it hepatitis A, B, C, D, E? You can't answer that just from that presentation. They all could do that. And all forms of acute hepatitis give an increased direct bilirubin. Indirect is from hemolysis, direct is from obstruction and hepatitis, viral hepatitis. There's an increased ratio of alanine aminotransferase, ALT, to aspartate aminotransferase. That's because viral hepatitis tends to elevate the ALT, and drugs tend to increase the AST. Drugs including alcohol. So viral with the AL and drugs with the AS can also increase the alkaline phosphatase when it damages the liver enough. Now, why you get aplastic anemia as a rare complication of acute hepatitis is unknown. But it does. It can suppress the marrow. But I could say the same thing about why does Epstein-Barr do it or CMV. What you have to know is a person comes in with hepatitis and they have pancytopenia. Why? Well, one can be just the virus. Just the virus by itself can do it. Which of these correlates with increased mortality? Which of these tests will tell you? Elevation of which of these tells you who's going to die? The answer is the prothrombin time. And that's because this tells you that there's no synthetic function. You damage the synthetic function. You could have transaminases very high, bilirubin is very high, alk phos very high, but you know what? They'll all get better fast. They can all be markedly elevated and better fast, but not the prothrombin time. If your prothrombin time is up, it means you're lost liver. Remember, your prothrombin time doesn't even begin to go up until you've lost 70 to 80% of your liver. By the time your liver is damaged enough to have an elevated prothrombin time, the majority, and I mean majority, I'm not using that word lightly, I mean majority of the liver is destroyed. But if you lost 1 or 2 or 3%, a tiny amount of liver dysfunction can elevate your transaminases. And it pop back, you could regenerate it. But not so with your prothrombin time, because all the clotting factors are made in the liver except factor 8 and von Willebrand's factor. They're all made in the liver except factor 8 and von Willebrand's factor. The disease-specific test for hepatitis A, C, D, and E, the best initial test for all of them is the same. IgM antibody, and IgG is long-term, tells you that your infection is resolved. So IgM tells you got an acute infection. IgG tells you it's resolved. That's the same for all of them. Hepatitis C has tests for disease activity. The PCR RNA viral load level tells you the amount of active viral replication. Many people could have a hepatitis C antibody, but it doesn't mean there's any significant active viral replication. We get the hepatitis C PCR to tell you if there's active viral replication, because if there's a hepatitis C PCR level that's up, it means you need to treat that person. Now, it's the first thing to change with treatment. First thing to change. If the PCR drops, you improve the treatment. If the PCR rises, it's a treatment failure. PCR for viral load tells you the response to therapy. Genotyping of hepatitis C predicts who's going to respond. The genotype. There's subtypes of hepatitis C. Why are they important? Because they can tell you who's likely to respond. The biopsy tells you how much damage has been done. The PCR, the viral load, tells you, has there been improvement? Has there been treatment failure? Genotyping tells you the subtypes, and the subtypes tell you, gee, which type is going to respond. Hepatitis B is the one that has difficult serologic patterns, but nothing has changed in 25 years. But hepatitis B is the one that has surface antigens, E antigens, core antibodies. If the surface antigen is positive, it means you have active viral replication. When your hepatitis B infection is old, past, healed, resolved, there's no more antigen, surface antigen. So the most important thing to determine chronic hepatitis is the surface antigen. If the surface antigen is going on, still positive for more than 6 months, it is, by definition, chronic hepatitis B. Chronic hepatitis B is defined as the persistence of surface antigen beyond 6 months. E antigen tells you early antigen, yeah, but it doesn't go up first. Actually, surface antigen is first. E antigen tells you the degree of viral replication. It's like saying DNA polymerase. So E antigen is always up in acute hepatitis, might be up in chronic, but E antigen indicates active viral replication in high quantities. Consequently, for a resolved, old, past, or healed infection, it's gone. Core antibody is looking at a resolution. Now, it could be that it's only just starting, so it could be an IgM. So the core can't tell you whether it's acute or chronic. It just can't. We know that an IgG core is what's up when you have a healed infection. But you should not look to core to tell you whether it's an old or acute infection, whether it's acute or chronic. You can't. You can't. What we look to core for is to tell us, is your surface antibody, is it up because it's resolved infection like this, resolved infection as surface antibody? Or is it up because it's from a vaccine? If it's from vaccine, there will be no core. Vaccine gives no core. Surface antibody does not exist at the same time as surface antigen. When the surface antigen goes away, there's a little window period of 2 or 4 weeks, and the surface antibody comes, but they don't exist at the same time. Being able to distinguish between the type of serologic pattern is very important for answering the question, hey, which of the following serologic patterns is most likely to be found in this patient? Vaccinated patients never have surface antigen. And in the window period, well, the window is defined as the surface antigen going away. Surface antigen is gone, and surface antibody has not begun. That's the window. Highly exaggerated. It's only 2 or 4 weeks, very small. E antigen is never up in vaccine. And in the window means it's resolved because E antigen is only up when the surface antigen is up. E antigen is only up when surface antigen is up. Now, this is the whole point. Core antibody is not made with vaccine, but it is there in the window period. That's the major point. Surface antibody is positive with vaccine, and that's the whole point. Vaccinated patients only have one thing, surface antibody. And the window is called the window because the surface antibody has not had time to develop yet. That's why it's a window. Which of the following becomes abnormal first after acquiring hepatitis B? The first thing that goes up is surface antigen. Most common wrong answer is E antigen. Well, that's understandable. It's called early antigen. You would think it would come up first, but it doesn't. Surface antigen first. Before there's E antigen, there's surface antigen. Okay, viral replication rises after surface antigen. Bilirubin is after the infection has occurred and damaged the liver cell. Transaminases after infection has occurred and damages the liver. The core antibody happens just after surface antigen, but certainly there's a delay of several weeks to months. And they're the body's in response to infections, not the actual infection. Surface antigen is the actual infection. By the time you make anti-hepatitis B E antibody, you have started to resolve. Anti-hepatitis B E antibody is the very definition of I'm starting to resolve. Which of the following is the most direct correlate of the amount or quantity of active viral replication? Now, this question has enormous significance because this tells us who to treat. And we have so many therapies for hepatitis B now, for chronic hepatitis B, that this issue of, gee, which of these tells us the quantity or the amount of active viral replication? That is E antigen. It could be either E antigen or DNA polymerase. Surface antigen is not quantitative. It's either positive or negative, positive or negative. You could be a carrier. Carrier is a term applied to people who just walk around with surface antigen and nothing else. It could be very low level viral replication. E antigen tells you DNA polymerase. Surface antigen just doesn't tell the quantity, Neither does bilirubin. Core antibodies, resolution, same as ALT. There's a response, and anti-hepatitis B and E, they appear prior to resolution of all the DNA polymerase activity. They tell you you're on the way to resolution. But E antigen is the most direct correlate of quantity. If your E antigen is positive, you have a 90% chance of transmitting to the baby. E antigen transmissibility. Which indicates you can't transmit infection. The active infection is resolved. I can't transmit. Which of these means you're over transmission? The answer is that there's no surface antigen. As long as there's some degree of surface antigen, you can still transmit. Now, E antigen and bilirubin normalizing are good. Transaminases mean very little because most people, about half the people with chronic hepatitis who are still replicating virus, they can have normal transaminases, even a normal bilirubin. So normal ALT and normal bilirubin don't mean that the infection is resolved. It means that the acute infection is resolved. It means the acute infection is resolved. You can still have chronic. Matter of fact, most people with chronic have a normal bilirubin and transaminase. So these normalized long before viral replication stops. E antigen is a measure of quantity. As I said, if you have E antigen, the viral replication has stopped, but there's still some as long as your surface antigen going on. No core is not specific enough. That just means there's no serologic evidence of disease. An E antibody, hepatitis B E antibody, appears prior to the resolution of all DNA polymerase activity. But the key issue is, although the others determine intensity, quantity, and degree of severity, as long as there's still surface antigen, you can still transmit. You can't transmit when the surface antigen is gone. Which is the best indication of the need for treatment in chronic disease? A very big deal. There are not enough livers for everybody. the one that is the best indication for the need to treat is actually E antigen, because this is the one where you can actually do something. Now, it may seem paradoxical. I just said surface antigen tells you can still transmit. But since low-level, tiny amounts of viral replication are hard to control, the greatest knockdown, in other words, is with E antigen. That tells you got something to really inhibit. At least some disease, some active disease, it might be on its way to spontaneous resolution. It wouldn't benefit the surface antigen. In other words, maybe the surface antigen was about to go away, and this treatment goes on for months and months. So we treat the people with E antigen. Bilirubin means a big nothing. Same as the core antibody, same as the transaminases. 40, 50, 60% of the people with chronic hepatitis can have normal liver function tests and transaminases. Doesn't mean anything. Anti-hepatitis B E antibody tells you that the person doesn't need treatment. It's the other way around. The indication for the need is E antigen or DNA polymerase. Anti-hepatitis B E antibody means you don't need to be treated because you're on your way to resolution. The body's response to infection shows it's a measure that the body has responded to infection. With E antibody, you don't need treatment. E antigen means lots of viral replication. E antigen, 90% of the mothers will transmit to their babies. E antigen is a qualitative test to be, tells you positive, negative, positive, negative. If it's positive, doesn't mean how positive. You need DNA polymerase for that, for the quantity. E antigen for the quality. Positive, negative is quality. The best indicator that a pregnant woman will transmit to her baby is E antigen. Surface antigen might be on its way to resolution, might get better any minute, but E antigen, you only have 10% transmission if the surface antigen is positive, but E antigen is negative. E antigen negative, 10% transmit. E antigen positive, 90% transmit. Bilirubin, core antibody, ALT, and these others don't tell you. If you say to the woman, I think you're going to transmit, it's based on E antigen. The others are a measure of the body's response to infection. Well, what's the treatment for acute hepatitis? Well, for hepatitis A and E, the answer is nothing. There is no treatment that we have that's effective. In any event, even untreated, it resolves spontaneously over a couple of weeks. There are essentially always benign conditions in almost everybody except people who have underlying very serious liver disease. Now, for hepatitis B, you become chronic in about 10% of cases, and there's no predicting who is going to become chronic, and we have no treatment for acute disease. We have treatment for chronic disease, but not for acute disease. The only form of hepatitis that has treatment with acute disease is hepatitis C. We use interferon ribavirin and either telaprevir or boceprevir in acute hepatitis C. And this treatment decreases the likelihood of developing chronic infection. Only acute hepatitis C gets medical therapy. Chronic hepatitis B means surface antigen greater than 6 months. Period. That's it. End of story. E antigen means elevated levels of DNA polymerase, and you treat when both the surface and E antigen are positive and the DNA polymerase are positive, because these are the people that derive the greatest benefit, because you have the most to block. Now, here we go. I want to be clear about this. Hepatitis C, as in Conrad, gets 3 drugs. Hepatitis B, as in boy, 1 drug. Combination therapy, not used. Entecavir or adefovir or tenofovir or lamivudine or tebelvidine. Any one of them. 1. No treatment for acute hepatitis B, and chronic is monotherapy. Interferon I've put specifically at the bottom for 2 reasons. Number 1, since it doesn't have greater efficacy, first we start with efficacy, then adverse effects. And since it has worse adverse effects, it's last. Next, step 2 tests route of administration, and it's an injectable medication. It has the most adverse effects, the hardest route, and no greater efficacy. That's why it's last. Hepatitis C combo, interferon ribavirin with C as in Conrad, interferon ribavirin and telaprevir or boceprevir. 3 drugs for C, 1 drug for hepatitis B, and only when it's chronic. The adverse effects of interferon are probably the single most frequently tested thing on interferon. Arthralgias, myalgias, aches and pains and flu-like symptoms, and lowers whites and platelets. Wow. Not only that, it makes you feel crappy, and it screws up your CBC, and makes you depressed and achy and painy. You know when you have the flu and you're like, I feel crappy. That's interferon in your body. That's your interferon. That's what makes you feel crappy in the flu. And the goal of hepatitis therapy, the goal is to get rid of the DNA polymerase and convert E antigen to hepatitis B E antibody. That's how you'll know when you've improved. You get rid of the DNA polymerase and you become E antigen negative.
Now, what is the role of liver biopsy? Since fibrosis is a very strong indication to begin therapy for either hepatitis B or C right away, fibrosis and active viral replication really relieves cirrhosis very rapidly, and cirrhosis is irreversible. It answers the question, who's going to progress? Older terms such as chronic active hepatitis and chronic persistent hepatitis are not helpful anymore. They've been discarded. And that's because DNA polymerase level is helpful to know, hey, I have active viral replication. I need to go on treatment, not using a biopsy to find chronic active or chronic persistent hepatitis any longer. Now, one of the reasons that the liver biopsy can be very useful is that the ALT levels just aren't a good indication of chronic hepatitis activity. You can have very significant infection with normal transaminase levels. Often the only way that you can really know how much damage has there been to my liver is to do a biopsy.
There's no way to determine the duration of infection with hepatitis C since there's no equivalent of a surface antigen test. In hepatitis B, you have acute symptoms, you feel crappy, you feel tired, you turn yellow, you got dark urine, you have weight loss. We tested you. Oh, look at this. On June 5th, you became surface antigen positive. Now we wait. But hepatitis C doesn't have that. And that's because 80% of people never felt acute hepatitis C. So since most patients don't have acute symptoms, you can't base it on the time course. If the PCR RNA viral load is elevated, patients should be treated with interferon and ribavirin and boceprevir, all 3 drugs. Interferon, ribavirin, and telaprevir, all 3 drugs. The standard of care for hepatitis C is 3 drugs. There's an 80% resolution with 3 drugs, interferon and ribavirin, and either telaprevir or boceprevir. And the final point is ribavirin causes anemia as its adverse effect.